Hello and welcome everyone. Today we'll be looking at the complement system and how can we target it to treat critical illness. The complement system has four main functions: the lysis of pathogens, the opsonization, activation of the inflammation, clearing immune complex and dead cells. The tight regulation is crucial for this pathway to prevent excessive inflammation and tissue damage. Factors such as CD55 and CD59 along with factor H help protect the host cell from damage. So this is a diagrammatic representation of how the complement system has its four primary function, how it does the lysis, the activates the inflammatory response, opsonization helps in the opsonization, and finally how it clears the immune complexes. The overactivation of the alternative pathway can lead to excessive inflammation and tissue damage, targeting organs like the endothelium. Complement regulation is especially important in critical illness where the overactivation could lead to severe tissue damage or inflammation. The system has four levels of control to prevent unwanted activation and damage. The first is C1 esterase inhibitor, which regulates the classical and the lecithin pathway. Regulators like factor H and factor I prevent the unwanted C3b deposition. Proteins like CD46 and 55 prevent excessive activity of C3 and C5 convertase. CD59, clostrins, and vetronectin stop the formation of the membrane attack complex that lies the host cell. So this is the complement pathway text, and this is the inhibitors which are regulating the inflammation. And so how is the complement system getting affected in critical illness? It plays a major role in the inflammation because we mostly have septic patients. Complement and the coagulation system are interconnected, impacting blood cells and endothelium. In sepsis, the release of C5a leads to tissue damage, increased infection rate, higher thrombosis due to tissue factor and plasminogen activator inhibitor 1 upregulation. Dysregulation contributes to the DIC with C3a and C5a promoting cytokine release, leukocyte attraction, and increased vascular permeability. C1-INH, that is C1 esterase inhibitor, which regulates the classical pathway, is often decreased in sepsis, worsening overactivation. Supplementing this can improve outcomes in sepsis. So, complement in respiratory and COVID-19 conditions. Excessive complement activation occurs in ARDS, but studies till now have shown mixed results. Overactivation of the complement system is seen in severe COVID-19 and it was associated with worse outcomes. However, trials of complement inhibitors like C3 blockage and Riluzumab in severe COVID-19 was not found to be of any significant benefit. Bradykinin related angioedema. Unlike histamine mediated angioedema, bradykinin mediated angioedema does not respond to antihistaminics and epinephrine. Here, hereditary or acquired conditions can be seen. Pathophysiology involves excessive bradykinin release to increase the vascular permeability and edema. Treatment options here are the C1 inhibitor concentrates, bradykinin receptor antagonists, kallikrein inhibitors. In case of unavailability, we can also give FFP. Complement system inhibition has become a significant therapeutic advancement, particularly in the development of the drugs that block specific complement components. The first one is the eculizumab. It inhibits C5, preventing the formation of C5a, which is a pro-inflammatory molecule, and the membrane attack complex. It is approved in USA in 2007, in Europe in 2001. It preserves the C3b and C4b opsonization and C3a signaling systems. Adverse effects include, though it's generally well tolerated, headaches are commonly seen. A rare but serious complication is Neisseria infection, with some cases resulting in meningococcal infection as well. Now the next is ravulizumab. It is engineered from the eculizumab but has a longer half-life, thus reducing the dosing frequency. It has got the same mechanism of action, that is C5. Despite the improvements, continued research is needed with new biomarkers and health economical evaluation. The next we have the statin based drugs. These are the AMI 100, which inhibits the C3, pegcetacoplan, which is approved for paroxysmal nocturnal hemoglobinuria and geographic atrophy. We next have the zilucoplan, which is C5 inhibitor, which is approved in 2023 for generalized myasthenia gravis. We have some newer C5 inhibitors like Nomacopan and Zilucoplan. Now, these show high efficacy in patients with C5 variants, unlike the original eculizumab. These drugs are well tolerated and the risk of Neisseria infection is minimized with proper infective measures. The infection risk is to be kept in mind, that is the Neisseria infection. Ongoing research is going on to find better safety and efficacy as well as looking at patient related outcomes. So there are two conditions where the complement system is very importantly affected. The first one is the atypical hemolytic uremic syndrome. It involves kidney failure, hemolytic anemia, and thrombocytopenia. It's a part of the thrombotic microangiopathy family, characterized by thrombi in the capillaries and arterioles due to alveolar injury and dysregulated coagulation. Renal involvement is the hallmark of HUS. The classification is, we have TTP, where there is deficiency of ADAMTS 13. We have atypical HUS, which is driven by inherited and acquired dysregulation of the complement's alternative pathway, and the secondary HUS, which can result from other disease or drug exposure, complicating the diagnosis. So the complement dysregulation, that is the atypical HUS, involves complement dysregulation triggered or worsened by infection, medication, or autoimmune disease. Around 62% of the atypical HUS show rare variants in complement genes such as CFH, CFY, and different genes. The diagnosis over here requires excluding the TTP and secondary HUS. For treatment purpose, we go for plasma exchange, which is the initial treatment until TTP is excluded, followed by eculizumab without waiting for further complement biomarker results. Plasma exchange alone is not favored due to the poor long-term renal outcomes. Pregnancy and malignant hypertension. Pregnancy-related atypical HUS is triggered by systemic endothelial stress during pregnancy, with complement inhibitors like eculizumab being safe and effective therapy here. In malignant hypertension can be either because of secondary TMA or be a manifestation of atypical HUS. The hypertensive emergencies often complicate atypical HUS, particularly in patients of African ancestry. So the therapy with eculizumab and other complement inhibitors show benefit with both renal and hematological parameters. Eculizumab can be used prophylactically, especially in kidney transplant patients with high risk of recurrence. Early initiation of eculizumab is critical for improving the renal outcome in patients with atypical HUS after transplant. Regarding the complications, serious complications include the meningococcal infection, so vaccination and preventive measures are important. Long-term complement inhibition requires careful evaluation with relapse risk factors like female sex, rare complement variants, and high plasma C5b9 levels. Regarding the future research, developing reliable biomarkers to detect the complement activation is important. Advancement in rapid genome sequencing for detecting the mutations is also going to be important. So this is the pathway. How do you diagnose the atypical HUS? First, you suspect that it is TTP and start your plasma exchange. Then if you do find that there is ADAMTS 13, then TTP is ruled out. Then you try to find if it is a secondary HUS. Then you look for the causes that could be related to secondary, like malignancy, transplant, autoimmune, or any medication exposure. So these are the tests that you can do. Next, if this also is ruled out, you go for typical HUS, where you screen for the Shiga-like toxin. And if this is comes out to be negative, then this is ruled out. Then you go for the complement or the atypical HUS. Then you can go for these therapies. You can go for this genetic testing for confirming your diagnosis. The next disease where the complement is very important is myasthenia gravis. It is a rare autoimmune disease affecting the neuromuscular junction, leading to chronic muscle weakness. Muscle weakness worsens over excretion and fluctuates over time. Ocular myasthenia gravis involves the eye muscles and affects 15% of the patients, while generalized occurs in the rest 85%. The symptoms include bulbar weakness and, in severe cases, respiratory weakness, which may lead to ICU care. Now, the cause of myasthenia gravis in 85% is because of an autoantibody against the nicotinic acetylcholine receptor in the neuromuscular junction. These antibodies activate the complement pathway, releasing the C5a and forming the membrane attack complex, which damages the postsynaptic membrane. Other autoantibodies include the MuSK antibody in rare cases. Antibody against low density lipoprotein receptor related protein is also seen. How is complement inhibitor going to help? The eculizumab and the ravulizumab, that is a C5 inhibitor, show significant improvement because they reduce this MAC formation. These treatments are generally well tolerated, but we all know the infection risk. The newer agents have demonstrated similar benefits with better patient profile. The clinical guidelines, mostly from Japan and Germany, recommend using complement inhibitors for patients who have acetylcholine receptor antibody positive generalized myasthenia gravis. So this diagram basically shows the antibody that are produced. The most common one is this, the anticholinesterase. The others are given over here. This is anti-musk and LRP4. This is the musk and this is the LRP4. This antibody results in release of the complement. It activates the complement and damages the postsynaptic membrane. So this is the MAC complex which is attacking and damaging the postsynaptic membrane. The take-home message is the complement system is essential for immune defense, inflammation control, and interaction with the adaptive immune system. While it helps to eliminate the pathogen and maintain the homeostasis, overactivation can result in tissue damage and excessive inflammation. Complement dysregulation is seen in various diseases, as we have already discussed. Genetic factors can impair the regulation of the complement system, resulting in excessive inflammation. So we have certain inhibitors which have been used in these cases like atypical hemolytic uremic syndrome and generalized myasthenia gravis. We need to understand that this use of these drugs is associated with infection risk, especially Neisseria, which can be as high as resulting in meningococcal infection. These therapies are costly and more research is needed to determine the optimal duration for individual patients. Ongoing research is evaluating the complement inhibitors and the pharmacotherapy options. There is a need for early diagnostic tools to detect complement driven disease before the symptoms actually happen. If there is already excessive inflammation, it will be very difficult to control it after it has already been initiated. We need early diagnostic methods to detect these systems early. So finally, I leave you with the therapeutic options which are targeting the specific areas of the complement pathway and how and we are going to probably use them in future in treating patients who suffer from complement overactivation or complement dysregulation. Thank you for your patience.